I'm Dr. Paul Johnson. I'm a board-certified orthopedic spine surgeon with Orthopedic Associates of Wisconsin, with our primary office in Milwaukee and other offices in Brookfield and Monaco, Wisconsin as well. And I put together a little presentation for you all on lumbar facet arthroplasty, which is a motion-preserving alternative to fusion. So before we get into alternatives to fusion, we have to understand the problem to begin with. And so to understand the problem, you have to understand some basic anatomy and biomechanics of the spine. So in the spine, the motion unit is composed of the intervertebral disc, as well as the vertebrae above and below, with the paired facet joints in the back. The disc carries most of our load, whereas the facet joints give us a large majority of our range of motion, as well as the quality of the range of motion. And that is flexion, extension, as well as rotation. Now, stenosis happens because of wear and tear of the joints. And even though the spinal motion units are distinct from our hip joints, which are a ball and socket joints, or hinge joints, such as in our fingers or our knees, they are still synovial joints, meaning that they have a synovial lining, and these joints are still made up of bone, hyaline cartilage, the lining, as I mentioned, as well as a fibrous capsule. Now, as that cartilage thins out, the underlying subarticular bone sees more stress, and the joint will begin to enlarge. Additionally, inflammatory mediators are released, and this will cause reactive bone growth, known as osteophytes or bone spurs, as well as a thickening of the ligamentum flavum. Now, this will result in spinal stenosis. Stenosis of anything is narrowing of a tube, and in your spine, it's a narrowing of the tube where your nerves go through. Now, this is still an identical process to what we see in the other synovial joints. And as the joint loses its integrity, it can allow one vertebrae to slip forward on the other, which in the spine is known as Spondylolisthesis, with the origin in Greek. Now, this is considered a form of instability according to a common grading system that we use in orthopedics. Now, as I mentioned, stenosis of anything is narrowing of a tube, and in your spine, that narrowing is caused by the degeneration. As those facet joints wear out, they enlarge, and in combination with degeneration of the disc, it will cause narrowing of the tube for your nerves in three distinct zones: the central zone, the subarticular zone, which is the zone underneath the joints, as well as in the foramen. And this will lead to patients having pain in their buttocks and or down their legs, known as neurogenic claudication or radiculopathy. Now, in order to take care of this, patients oftentimes need surgery. Now, the goal of any surgery is to decompress the nerves and leave your spine in a stable position. If the spine is unstable, fusion leads to better results than decompression alone, but this comes at a cost of loss of range of motion and unnatural force transfer that can lead to adjacent segment disease. So, for a long time, we've searched for another option, and the TOPS system is that new option. Now, TOPS stands for Total Posterior Spine System, and here is an illustration and a photograph of what the device actually looks like. Now, although this is a newer option, it has been around for quite a while in improving form since at least 2005. So this is not a brand new system with no track record. It has actually an excellent track record and has been continuously refined. And here's a video showing that motion in flexion, extension, as well as rotation. Now, it is fixed to the spine using the same standard pedicle screws that we are very well acquainted with and have an excellent track record. And the rest of the device as well is made of other materials that we're very, very familiar with and have excellent track records. Titanium, PEEK, which is polyether ether ketone, which is a very widely used orthopedic implant material, as well as a urethane plastic. Now, candidates for TOPS are patients who have grade 1 degenerative spondylolisthesis at the L3-4 or L4-5 levels. You need to have at least 5 millimeters of disc without modic end plate changes, no more than 10 degrees of coronal plane scoliotic curvature, no lateral listhesis, no osteoporosis, and be between the age of 35 and 80. Big exclusions are osteoporosis, a BMI over 40, less than 5 millimeters of disc height or disc herniation, or a large deformity. Now, for any orthopedic device, this has to go through very extensive testing, and the TOPS system did do that. They actually ran a very nicely done, very large study. They had 6 primary endpoints, which are listed here. And in order to be considered a success, they needed to, or patients needed to accomplish all of these endpoints. And at 24 months, we can see here that the TOPS system actually had overall composite clinical success score significantly higher than fusion, without considering fusion status, and even when considering fusion status, even more so. And so according to the FDA, the conclusion that has to be drawn from this data is that when the inclusion criteria are met, TOPS is a superior option to lumbar fusion. And here is additional x-rays showing that this device actually does maintain motion in vivo. This is even more impressive than you might realize. There are a lot of devices out there that if you look at them on paper, they look great and you think it's going to be fantastic. And then you put them in the body and they seize up. Cervical disc arthroplasty frequently seizes up. A lot of hip joint arthroplasties also seize up in vivo. And what we see in the TOPS is that it really does keep that motion. So it's not just a fancy fusion. Here's another illustration showing that additional sideways bending, showing that this motion that we are trying to achieve really does exist in the body. So here is my contact information. My secretary is Haley Leader. That is her email there, and that is her direct phone number. We have another main line. However, if you want to get a hold of me directly, this is the best number to use. So, are there any questions?
There are. Let me read you the first question that's come through. A prospective patient is asking, if you have muscle atrophy, does releasing the nerves bring the muscle innervation back?
It depends on what muscle we're talking about and how long it has been present. If the atrophy has not been present for a long period of time, there is a potential that by releasing the nerve, the atrophy could come back. If we're talking about paraspinal muscle atrophy, probably not. But if we're talking about atrophy in an extremity, there is a potential that that could come back, depending on the length of time that it has been present.
And what are the ramifications of that muscle atrophy?
The ramifications of that would be weakness. The reason your muscle atrophies if a nerve is pinched is because that signal from the nerve is not getting to the muscle, and without nourishment of the neuromuscular junction where the nerve actually inserts onto the muscle stops contracting and then atrophies. And so the ramification would be persistent weakness.
Okay. Another patient is asking whether you think TOPS is relevant for patients who suffer from osteopenia, and is it relevant for patients who suffer from osteoporosis?
So as I said, unfortunately for patients with osteoporosis, you can't put it in that state. For osteopenia, I would want additional testing to see exactly how osteopenic the bone was. I can order a CT scan to assess that. And if the bone is borderline or osteoporotic, I actually work with an excellent bone health specialist, and we routinely send people there, and he can get their bone density up in a matter of months, and then you could be a candidate for it.
So in other words, if you have poor bone quality, there's an opportunity to strengthen your bone and then undergo surgery?
Yes. And if that's something that someone wanted to do, I would highly advocate for that. And actually, if someone had osteoporosis, I would advocate they get that treated whether or not they want to have spine surgery. That's really something you don't want to go around with.
Understood. Another patient is asking about patients with multi-level disease. Could you kind of walk through your thinking of how to treat a patient with more than one level of stenosis and possibly one level of spondy or 2 levels of spondy?
Yes. So the TOPS is still an option in that case. There's a lot of possibilities that go into this. Now, I have treated patients with multi-level disease with the TOPS. Now, if someone has a single level spondylolisthesis and multi-level stenosis, what I would do is use the TOPS at a single level and then simply do a laminectomy at the other levels. If there are multi-level spondylolisthesis, there is a possibility to do a fusion at one level and a TOPS at another level. Unfortunately, right now, we can't do multi-level TOPS. I'm sure at some point in the future we can. But it is an option for multi-level disease. Exactly for any particular person, it's really going to depend on the precise scenario.
So if I understand correctly, it kind of runs the gamut from multi-level decompression without instrumentation to multi-level decompression with TOPS, multi-level decompression with TOPS and a fusion. So basically, you're going to look at this patient holistically and determine what type of hardware, if any, would be used at each level?
Absolutely. Every patient I see, I come up with an individualized plan for them, and all options are on the table.
Understood. How about if I've had a previous laminectomy or if I've had a previous coflex and now I've got problems at that level? What are my options?
Yeah, so for a patient in that situation, the TOPS is certainly an option, particularly with a previous coflex. I'm not a huge fan of that device. I don't put them in myself, but that's a very easy revision to the TOPS, which I think is a much better surgery. And if you've had a previous laminectomy and your disc is still healthy, but you have developed recurrent stenosis in the foramen, which is almost always where the further disease happens, TOPS is certainly a possibility as well. It's actually not too hard of a revision. All you do is cut through the pars, and I cut out those joints just like I do in a primary, and then put the device in, as long as that disc is healthy.
How about if I've had a fusion at 5.1 and now I've developed adjacent segment disease at 4.5? Is TOPS a possibility for that 4.5 level, even though I've already had a fusion at 5.1?
Yes, in that situation, in fact, that could be the ideal patient for a TOPS. There are a lot of patients out there who are, for whatever reason, very prone to developing adjacent segment disease. And so I think the TOPS is a great option for patients who have had a previous fusion and then soon thereafter develop adjacent segment disease. We know why that happens. And so what the data shows is that TOPS does help prevent that. And so I think this would be a great person for that scenario.
How about if I've had a fusion at 4.5, isn't working out for me, and my problem is still 4.5? Can you reverse an existing fusion and put TOPS in?
That would really depend on the person. My guess is probably not, but it would depend on why the fusion wasn't working out. What I would be worried about in that scenario is that the instrumentation could potentially be loose, or there could be a lot of other things going on there. I would certainly consider it, and if it worked, I'd be happy to do it. It would really depend on why exactly the fusion wasn't working out.
We've got a patient who's over the age of 80. And as you know, we had to come up with age criteria for the study, and the study requires long-term follow-up. That was the reason why we capped it at 80. I know this is not an on-label application. In general, how do you think about operating on patients over the age of 80?
Yeah, this all gets into the minutia of, how you have to run a study, and, you have to, identify an age range. And, I think the concern with patients over 80 is that they're more likely to have poor bone quality and be osteoporotic. They're more likely to have, advanced disc degeneration compared to younger patients. Now, you're right, technically this is an off-label use. However, simply being over 80, I don't think matters at all for the mechanics of the surgery. And so I wouldn't want to, advertise doing a surgery off-label. From a technical standpoint, as long as the bone quality was fine and the discs were fine, it doesn't pose any issues.
So putting TOPS aside, do you operate on patients over the age of 80 and other than
all the
bone
time.
quality? All the time. And so how do you assess whether someone over the age of 80 warrants spine surgery or is better off not having surgery at all?
Yeah, so my criteria are really the same, whether you're 80 or you're 50 or you're 40. What I'm really operating on is patients with nerve pain. And unfortunately, if you have something mechanically pinching on your nerves, at a certain point, surgery is the only thing that's going to make you feel better. And so I have a really hard time telling someone that they have to live in pain for the rest of their life when I could fix them simply on an age cutoff. Now, obviously, sometimes someone has severe medical comorbidities, and I don't think they're going to survive a surgery. In which case, I tell them that I'm sorry, I can't do anything else, or maybe potentially the surgery they would need is very, very large. For everyone else, as long as they are reasonably healthy, and I think the size of the surgery they need corresponds to their health, I'm fine taking care of it. I have done lumbar fusions. The oldest I've done is on a 93-year-old because his health was otherwise okay, and he was crying in my office that he was miserable. And I couldn't honestly tell the man that I couldn't fix him because I could. And I fixed him, and he did very well. Now, is someone who is in their 80s or above at higher risk for anesthetic complications, longer recovery? Yes, all those things are true. But there can also be a fairly wide spectrum of people in their 80s. And I certainly have patients in their 80s who are in better condition than patients in their 60s. And so again, I really look at this on an individualized basis.
So we have another patient asking specifically about, let's say, an L4-5 segment that has stenosis, and there is some level of disc degeneration. It's rare you find a patient with stenosis and their disc looks like a pristine level. How do you assess how much degeneration or what kind of degeneration of the disc is okay relative to the stenosis in order to be able to use a TOPS device?
Yeah, so what I'm looking for, number one, is the disc height. So I'll measure that. I'm also comparing it to the other discs. Is one disc in particular really bad and the rest are fine? Are they all kind of equal? I will look for any modic changes, which are inflammatory bone changes along the disc. If I see those, that's a clue that someone's having a painful disc, in which case a TOPS wouldn't be a great option. But if they don't have those modic changes and you have at least the 5 millimeters of disc height and you don't see any disc herniations, I think the disc in that case would be fine.
Okay, someone you had mentioned earlier that putting a TOPS above a fusion could make sense, an existing fusion. How about putting TOPS below an existing fusion? Is that something you would consider?
I would potentially consider it. I would really have to look at the patient's overall alignment. Putting it below makes me a little more worried than putting it above, but it's not a hard no. Again, this really comes down to the individual patient and what their alignment is looking like, what their bone quality is looking like, because I don't want to put something in that maybe sees too much stress and fails earlier on.
Can you use TOPS in the cervical spine?
Unfortunately not. We do have options for the cervical spine. A facet arthroplasty in the cervical spine, I'm not sure would be as useful for patients. And you would have to come up with a different way to fix it into the spine as well, because the pedicles in the cervical spine are very, very small.
Understood. Someone in the audience with a very keen eye noticed that you did not reduce the spondy when you were doing a TOPS. It's common with fusion that you reduce spondy.
Correct.
What's your thinking about the necessity of reducing a spondy with TOPS?
Well, the device is designed to compensate for that. So I don't think you can really reduce it with a TOPS. Just the way you put that in, it's not designed to reduce the spondylolisthesis. It's designed to compensate for the facet joint. So if you wanted to reduce it, you'd have to do a fusion. But again, it's not entirely necessary. If you fix a fracture, you need to have the spine reduced. There's plenty of debate in the spine world, even with fusing, whether or not you have to reduce the spondylolisthesis. There's plenty of good data showing that you can fuse people in situ, and what matters overall is their global alignment. Now, commonly, we do want to reduce things as close as we can to make it as anatomic as possible. However, there are many very prominent and very, very smart and very good spine surgeons who can make very compelling arguments against it.
So along the same lines, there's a patient who's asking, why wouldn't you use TOPS for a grade 2 or a grade 3 spondy?
Yeah, what I'm worried about is just the forces on it. I guess number one, it has not been studied in that situation. Number two, I'd be worried that the forces on it are going to be too great for those screws in the device to be able to neutralize them. And then number three, there are usually some large alignment issues that come along with higher grade spondies as opposed to the grade 1 degenerative spondies. And so that's really a whole different animal, in my opinion.
And what do you think about using TOPS if a patient has scoliosis?
It depends what kind of scoliosis we're talking about. Are we talking about an idiopathic curve, which is almost always thoracic, and now they've got grade 1 degenerative spondylolisthesis well below that? Have they had their scoliosis fused, and now we're going to try to put a TOPS below that? That's not a good idea. If it's a degenerative scoliosis, we know that we can take up to a 10-degree coronal plane curve with no lateral listhesis. And the reason for that is that if the device is designed to function within a set parameter, you really need to be within those parameters. And this goes back to a lot of what we learned in hip and knee arthroplasty, where you have to have people in certain anatomic alignment. And if you don't restore that, you get early failure.
Understood. Maybe talk a little bit about kind of the process in terms of patient treatment. Obviously, patients don't wake up one morning with severe stenosis and spondylolisthesis. It's a process. Can you talk about how you treat patients over time leading up to surgery?
Yes. So surprisingly, sometimes people do wake up one day and they have symptoms from this, and they didn't before. And it's interesting that you would say that there's almost no way that would happen, except we see it all the time. And that's the same thing that we see in hip arthritis and knee arthritis as well. There are people going around who have severe degenerative changes, but for whatever reason, they aren't bothering them. Now, for the most part, this is a slow process over time. In the earlier stages, if people come and see me or one of my pain management partners, what I will do is start them on physical therapy. We can try some non-sedating muscle relaxers, try over-the-counter or prescription strength anti-inflammatories. And if people can function well enough on those, then you don't have to do anything else further. As the degeneration progresses, you can consider an epidural steroid injection, and we will order up to 3 of those in a year. More than that, I think you are starting to overdose on the amount of steroid you're getting, which can lead to osteoporosis or other problems. And so we don't like to do more than 3 injections in a year. But that being said, there are patients who, after they've tried therapy and medications, and we talk about what problem they have, they choose to forego injections entirely because they are essentially just a Band-Aid. And there are a lot of people out there who would rather get their problems fixed and move on with their life.
Understood. So let's move on to the surgery itself. How long does the surgery typically take?
Surgery takes me about an hour and 45 minutes. The nice thing about this surgery is that it's really a modification of surgeries that spine surgeons are doing all the time anyways. While it's a really great step forward in improving our care, it is not anything radically different than what we are already doing, which is really important in terms of reliability. And so the most important part about this surgery is getting pressure off the nerves. And the TOPS is nice because you perform a complete facetectomy, meaning I cut out the joints entirely, which gives patients the maximum room possible for their nerves. You couldn't get an extra millimeter more than what we are already giving patients. And then I put in pedicle screws just like I would for a fusion. There are a few little, potential minor changes in order just to get the device to fit right. But essentially, I'm putting in pedicle screws in the exact same manner that I would do for a fusion. And they're the same screws that I would use otherwise. So there's no changes there. And then I check everything with a live x-ray machine to make sure everything's in the right place. I use that same x-ray machine to help me size for the device itself. Then I lock it in place and I'm done. I will keep patients overnight, although I think a lot of patients could likely go home the same day. For logistical reasons, I just like to keep them overnight. I think it's easier on their spouses or their friends and family, and then they're ready to go home the next day. After surgery, I have about a sort of standard post-operative routine where for the first 6 weeks, I have patients wear a soft back brace around just to stop them from doing too much and protect their muscles to a degree. I don't want them doing any 10 pounds or repeated bending or twisting for that first 6 weeks. At the 6-week mark, they can be done with the brace, start lifting up to 25 pounds, then slowly progress their activities. I want them to slowly start building some muscle strength back. And then at the 3-month mark, they can do whatever they want. The other nice thing about the surgery is that there is a potential for totally skipping opioids in this surgery. Because I'm not trying to fuse anything, I can put patients on anti-inflammatory medications, which I can't do with a fusion. And so there is the potential to skip opioids entirely.
And how would that recovery compare to, let's say, your fusion patients? Is there any difference?
That's an interesting question, because theoretically, if you look at the surgery and really know what you're doing, there shouldn't be much difference. They look very, very similar. I can tell you my anecdotal experience is that all of the patients I've done TOPS on have recovered much quicker. And so that's my experience.
Any thoughts on why you think TOPS patients get better faster than a fusion patient?
Yeah, it's a question in my mind, for sure. I'm wondering if, taking away that range of motion acutely really bothers people, maybe more than we acknowledge or realize. And that if you can retain that motion, if people aren't nearly as uncomfortable early on. Ron, I think your microphone is muted.
You are correct. A patient picked up on what you said and asked after 3 months, when you say the patient can do whatever they want, does that include activities like golf or yoga, flexing and
Absolutely.
twisting?
Yes. At 3 months, I tell patients to go slow. I don't want you to go and hit a large bucket of golf balls right away. I actually let you start hitting your wedges and your putter at about 6 weeks with half swings. Progress your strength up. You can hit your driver at 3 months. I suppose the only thing I would be worried about long term would be heavy Olympic style weightlifting, which is what I tell everyone. So if you want to go back to heavy deadlifting or squats, I suppose you could, but I would have my reservations about it. Ron, I think your microphone muted again.
Last question that just came in. Patient with multi-level stenosis is asking, what would be the advantage of a single level TOPS in a multi-level stenosis situation versus doing a fusion at one or multiple levels for that type of a patient?
Well, the advantage would be retaining your range of motion. And if you look at the results of the study, the conclusion you have to draw is that it's a superior option in that case. Now, I can tell you the problem with doing a multi-level decompression and a single level fusion is that those levels you have decompressed but not fused are at very, very high risk for breakdown. And I have seen that all the time. And so you can certainly just fuse one level and then decompress the rest and then cross your fingers and hope it doesn't break down. What I can tell you is that in practice, I have not really seen that happen. And so the advantage of doing a TOPS in that situation is that now you're not abnormally loading any of those other joints. And so hopefully you won't experience any adjacent segment disease or recurrent stenosis. Thanks, everyone.